Hello, everyone. Welcome to another CP Solver virtual morning report. We're very excited for this session today. I discussed cases yesterday and the day before. So if you want somebody else, you can just vote in the chat and say, Brahim, you can go step up and discuss if you want. No, but I'm really excited to co-discuss alongside Ravi. Ravi is literally the sponsor for all of us in CP Solver, is always supportive, always helping out any IMG, literally hosting them at his house, having them do rotations with him and doing the sim lab, and sometimes hosts the sessions from the sim lab. And we've had a session where he gave us a discussion inside the simulation, and we had an active discussion about that. Ravi, do you want to say a word?
Oh, I appreciate that very kind introduction. Yeah, SimLab I love SimLab. It's just amazing. You just see the first time you bring a student in or you bring an intern in and you put them through a hypothetical case where it's a safe space, it's just mind blowing. And then the next question I get is, when can we do this again? So it's always a pleasure. And I just love taking the cases and things that you all make here and making a sim out of them. So I'm very enthusiastic to make a scenario from some of the cases that you have. And we have Abel Fazi who will present a case today for us. So do you want to unmute and also introduce yourself?
Hi everyone, I'm Khashayar, aka Abul Fazl. I'm a med student from Iran. And yeah, I hope it's gonna be a great session.
Yeah, thank you
Should
for
I
introducing
start?
yourself. I think let's just have a quick word from Harry and Julia as well, who are helping us with scribing and teaching points. Julia, you want to go first?
Sure. Hello, I'm Julia. I'm a graduate from Germany, and I'm very excited for today's case.
Hi everyone, I'm Harry. I'm a resident at UCSF, doing some teaching points today. I'm excited to learn some things from everyone.
All right. Thank you, Harry and Julia. And should we start with the first aliquot?
Amazing. So this is a story of a 56-year-old man who was referred to our center with suspicion of methanol toxicity. And I'm gonna stop there, let you guys discuss a bit before moving on.
What do you think, Youssef? That's interesting. A suspicion of methanol toxicity. I wonder what started that, but tell us what you think.
Yeah. Yeah, thank you so much, Kashayar. I think this is a very, very interesting start to the case. And to be frank, like I've never seen methanol toxicity in real life, or maybe I've seen it, but I haven't diagnosed it. But the way I think about it, or like any alcohol toxicity, is that its breakdown usually into like other acids can cause a anion gap, and some of these agents have an osmolar gap as well. And a lot of these agents have specific side effects, and based on the side effect and the profile on the chemistries, you get to like closer to a diagnosis. So usually the things I think of, for example, like there's a like compare and contrast, for example, methanol, ethylene glycol, and propylene glycol, where like methanol causes like visual symptoms, while ethylene glycol causes kidney damage and stones, while propylene glycol usually causes like an elevated lactate and just things inside the chemistry that we can detect. Uh, Other than that, I don't have a broad illness script for that. What about you, Ravi?
Yeah, I just have to wonder, like, what did this patient present with? Because it's rare. Like, you will get patients from the office. Well, they'll come in with an abnormal lab, maybe a low hemoglobin, maybe their kidney numbers are up, maybe the liver numbers are abnormal. But there has to be something that may have triggered this suspicion of methanol toxicity. So unfortunately, a lot of methanol is found in a lot of household agents, cleaning agents, and things. So it's very readily accessible, and I guess it is one of the most rapidly absorbed agents. So if this person had toxicity, comes to the emergency room, more than often than not, it's probably absorbed and giving charcoal, activated charcoal, and all the agents to try and prevent its absorption probably won't work because it's probably digested very rapidly. And then it undergoes, like you had outlined, a chemical process, being, I guess, methanol gets converted to formaldehyde, formic acid, and then there's depletion of the NAD from biochem, if I remember. But yeah, the toxic effects, I'm just wondering what triggered this. But then I also kind of harken back to what Uncle Bob always mentioned. If you are called for a patient with X, don't think X, don't anchor, wipe your mind or your slate clean and start from scratch and try and do the detective work yourself. So let's see what Cashier has more to offer us with the next aliquot.
So the reason the patient was referred is that unfortunately methanol toxicity is fairly common in Iran because alcohol consumption is illegal here, and people usually produce them at home, and sometimes when they're buying this, the alcohol is mixed with methanol, and we usually see these in epidemics. And in this case, the patient was brought in because he had experienced a loss of consciousness 3 days ago after consuming some moonshine at work. The patient was initially taken by his coworkers to another center, and he was discharged after waking up. There's no information available about the workup done in the other center. Now the patient is brought to us after experiencing another loss of consciousness after consuming moonshine last night. He lost his consciousness this morning at work. The patient is wide awake right now when he's brought to the ED by EMS personnel. He's awake and oriented ×3. He can speak in a normal voice, and his hemodynamics are stable. His immediate memory seems intact, but his recollection of events in the past few days are a little bit hazy. He changed his story about what happened around 3 times, and the timeline of events is confirmed by his brother who works with him and is present with him at the AR. He remembers events before the first time he went to the hospital and the events before coming here, but nothing from this morning. His immediate memory, again, is intact. His main concerns at the moment are diplopia and vertigo. He doesn't have any headaches, nausea, vomiting, or paresthesia. There are no signs of trauma on his body. And according to his brother, he was found passed out on his desk at work without any sign of seizure activity either times. And I'm going to give you his past medical history as well. Aside from the common cold he had last week, there is no pertinent past medical history, no history of seizures, strokes, or cardiac disease. There is no history of recent travels. He's an office worker without any known occupational exposures. He started smoking 6 months ago, and he's smoking half a pack a day now. He has a history of chronic alcohol consumption, at least 2 drinks every day with more on the weekend, and a history of binge drinking during holidays. He usually buys the alcohol from his usual dealer, but he got arrested about 2 months ago, so now he's making moonshine at home. There is no pertinent family history and no allergies.
I guess it's a great place to stop. But so what's interesting is patients having varied kind of symptoms, but can it be attributed to the methanol? Yes, there's all this surrounding circumstances of methanol use. And I'm just wondering if this patient has had such a presentation before, but there is history in the health-related behaviors of chronic alcohol consumption. So methanol, I guess, I've heard stories in the past up in Appalachia there was a time in the US where there was prohibition, so people turned to making their own kind of alcohol, and so methanol was one of the products that were made, and these were made or manufactured in these illegal factories or even car radiators up in Appalachia. The stories that I've heard, and there were times where patients would present to the hospital with blindness as a side effect from not appropriately mixing the chemicals or having a adverse reaction to this. So as the chat is highlighting, blindness can be a side effect of this. But this patient with this altered mental status is still, I mean, the landscape is very broad for something like this. And I think if we're trying to decipher if this is the methanol, again, you don't want to anchor, but I think just ordering a number of tests will help us to clarify if this is something in the range of a toxidrome. So like Yusuf had nicely mentioned, anti-gap acidosis and so on. So maybe doing the chemistry, getting an EKG, electrolytes. You could even do a methanol level. And if it was taken recently, the level may be high enough. And do we have a pretest probability high enough, close to say 80% to trigger treatment in this case? Maybe if the labs are done quite rapidly, and if we do see that urgently, we may actually administer some agent. So famiprazole would be the agent. Some places ethanol, which could be used in competition to then reduce the effect of the methanol. And if worst case scenario, I think dialysis could be implemented too. But you have to be urgent in this evaluation because of the toxic side effects that can develop from this. What do you think, Yusuf? I've never treated anybody for this before, but this is definitely we always when we're discussing, we always get these cases which kind of do push us a bit, which is great. It's great for building knowledge.
Yeah, Ravi, if you haven't seen the case, I've definitely not seen the case. But no, let me just start off with this is a good picture of like public health and how public health affects individuals. And one of the examples is like Goodhart's law. When a measure becomes a target, it ceases to be a good measure. Like when you say, I want to stop people from drinking, and then people end up doing other behaviors to like overcompensate for that, it ends up with like severe outcomes. But and this is like predisposes patient for this condition, which we would not have seen if there was like had accessible to alcohol, but that's like besides the point. And we see here like a patient who has clear alcohol intoxication plus methanol intoxication, and we're worried about complications related to that. And possible complications related to that include, like you mentioned, like accumulation of famiprazole in the visual, like the retina or optic nerve. But other things I'm thinking of are like things like a seizure. Also, like electrolyte abnormalities. Could have there been like a very severe like electrolyte abnormality that changed rapidly? I can imagine like the patient could be at risk for a tea and toast diet as well. And could they be having like severe electrolyte abnormalities causing this presentation? And then just in general for like loss of consciousness, we're thinking this is related to the severe ingestion, but the general framework for that is like, could there be a seizure or hypoglycemia that are mimics? But then the other big categories are like the demonic, like metabolic, infectious, structural, and toxic, but with a strong suspicion for this is like metabolic and less likely structural, although it could still be a little bit less likely.
Yeah, I just kind of like that. And Ellen also highlighted this in the chat, like still stay broad and suspect other things. A patient with history of maybe alcohol use disorder, methanol use in the past could come in with anything actually. So they could have consumed maybe even what they thought was methanol could be something else, like you had mentioned earlier, ethylene glycol. When I was in Eastern Europe, when there was a Russian invasion of Hungary, Ukraine, and so on, they told me stories of Russian soldiers even taking in the pathology lab formaldehyde and drinking that because they had run out of alcohol. So anything like that could be devastating. It necessarily might not even be methanol, it could be something else. So we may have to keep an eye out for other toxidromes that could manifest in this patient. All right. Back to you, Kashir.
Amazing discussion. Thank you, everyone. I'm going to give you his exams now. His vitals, he was a febrile with a heart rate of 88, a blood pressure of 130/80, a respiratory rate of 18, and he was saturating at 98% on room air. The patient is awake and oriented ×3. His pupils are equal size and reactive to light. There is no scleral icterus, no apparent hypertropia or ptosis on either eye. Heart sounds are normal without any murmurs or abnormal sounds. His pulmonary exam showed normal breath sounds with no dyspnea. His abdomen is soft, non-tender, and without distension. No sign of spiderangioma, no hepatosplenomegaly. His neuro exam, the patient is communicative with normal speech pattern without aphasia or dysarthria. His affect matches his mood, and while a little anxious, he's not distressed. Concentration, attention, immediate and distant memory is intact. Near memory, aside from the events surrounding his current condition, seems intact. The patient is experiencing vertical diplopia that remains the same throughout the entire field of vision. The patient's eye movement across the horizontal field is normal, but he cannot move his eyes vertically. The patient's diplopia improves when the patient is lying down. Head tilt doesn't change diplopia. There is no nystagmus. Confrontation testing didn't show any deficit in visual fields. He had normal corneal reflex, normal hearing, no deviation of the uvula, no facial muscle movements, abnormalities, and the jaw movements were normal as well. The patient can't swallow. His hill to shin and finger to nose exam were normal, and he had normal gait. His limb forces were 5 out of 5 on all extremities. There were no rashes.
Thank you so much, Khashayar. I can take the first go, Ravi. So it sounds like the exam here is notable for normal vitals and potential vertigo and diplopia. And Khashayar, can the patient not look up, or can they look down, or they just can't look up, basically?
The entire vertical field is just impaired. He can't move his eyes up or down, just the horizontal.
Okay, thank you. And in general, when we hear about diplopia, the big framework that I use is whether this is binocular or monocular. So a binocular diplopia basically is when the eyes are not aligned. And how to test for that is that if you close one of the eyes, then the diplopia goes away. That means the problem is not an alignment with the eyes. It's more an issue if they can see well, sorry, and you cover one eye and they can see well, then it was just an alignment issue. And that's binocular diplopia. And that localizes to anywhere from the any of the muscles supplying the eye movements to the neuromuscular junction, the nerve, or the nuclei. But monocular diplopia is when a patient has diplopia, even if they close one of the eyes and they still see double. That means the lesion is somewhere on the retinal field all the way to the occipital lobe, and on that pathway, basically. And usually it's more of like an ophthalmologic complaint or somewhere in the occipital lobe. And depending if it's like unilateral or bilateral, then that would change your differential diagnosis as well. In this case, we see that the patient cannot move their eyes vertically in both eyes, which makes me think that this is less likely to be in the muscles or the NMJ. It could be bilateral nerves, or it could be more likely like in the CNS. What are you thinking, Ravi?
I think you did a great walkthrough of diplopia. It can be very difficult if it's something that you don't usually or encounter or work up. It can be difficult, but just utilizing what we've actually discussed this before, I think. But with diplopia and vertigo, I do love this or talking about this HINTS test. Somebody also hinted at the HINTS test. So that can be very powerful in this patient if he's able to then tolerate walking through the HINTS test. And it's a very good test in a patient with vertigo to try and decipher if there's a central or a peripheral process like vestibular neuritis. So in this test, you would first do a head impulse test. And in this case, when you move the head about 30 degrees, 20, 30 degrees, and you move it back centrally, if there's absence of a catch-up saccade and it's fixed, then that could be concerning for a stroke. Then you look for nystagmus. In this patient, I was looking through the exam. If you have bilateral, say this patient has bilateral nystagmus on both sides, if it's not beating to just one side, but both sides, that also could be concerning for a stroke. And then you do also a test of skew deviation. You look at these videos on YouTube where you cover the eye and then you remove the hand and there's a catch up with the eye that's uncovered. So when there's presence of vertical skew, that could also register a central process. So it's a very powerful test, and it can be helpful when you combine diplopia with vertigo. But in this patient, I think, yeah, you have to decipher, is this secondary to the toxidrome, or is this due to a central process? And then, I don't know about this diplopia improving when lying down, which is a very, very interesting. So does this signify maybe some pressure-like manifestation in the CNS or intracranially that could be, when you lie down, what changes, what shifts, right? So the effect of gravity. So when you're standing up, blood moves down, but that the heart will compensate. CSF may actually also shift down. But when you lie down, then there's equilibration of all these different fluids and structures. So this definitely has some bearing on it. Maybe there is something intracranially that is causing pressure, and it gets better when lying down. I'm just kind of wondering if I haven't really explored this domain, but I'm very excited to learn about this, and especially this change in posture. Any other thoughts, Youssef, at this point?
No, I really like the idea of, like you mentioned, like could this be intracranial hypotension? Although it's usually the common causes of intracranial hypotension, it can cause diplopia, but usually like associated with like a CSF leak. That's usually associated with either like connective tissue disorders or trauma. I don't know if it's associated with other like conditions other than connective tissue disorders and trauma. And usually it's diagnosed also on imaging, where you see like a different like pattern of enhancement, and then you do like a myelogram to detect a leak. But I haven't seen it in like non-traumatic cases or in here in this presentation where we see a particular toxicity.
So what's great, Youssef, is we're at the 1:25 p.m. mark EST, and we could actually utilize the crowd, do some breakout rooms for a few minutes and see what the crowd has to say. So let's pause the recording and break out and see.
Oh, welcome back, everyone. This is a very interesting case. So we're gonna ask if like there's any volunteers from room one, which is like Adam, Lucas, Olin, Rawaju. Anybody want to like say what you all discussed or what you want to do?
I can share a couple of thoughts. We, this is, I work as a hospitalist. I definitely have tried to stretch my brain to think of cases like this. I can't think of any offhand. When I think of I guess that I'd have to check myself, and but things that affect the midbrain, I think, would come to mind. If there was pressure, for example, or some kind of process affecting the midbrain, I think of that as potentially causing issues with diplopia, vertical diplopia, perhaps. I think of more structural stuff. It's hard when you think of like infections, that would cause some of this. We obviously worry about vascular issues. You can think of positional changes could do affect like circulation, for example. And so would that explain why the symptoms improve? Whether it's a circulation issue, whether it's a MASH and you're improving the pressure for that reason with positional change. Yeah, those are some of the thoughts. I'll let other people share as well.
Thank you.
Yeah, thank you, Adam. This is similar to what we were thinking. We haven't seen this before, but we're trying to like come up with analogic reasoning, trying to localize the lesion and see what we would do next. The second room was Amit, Julia, and Catherine. I don't know if somebody wants to participate.
I think Alan has had some great thoughts. Do you want to share them with us? I like them.
Sorry, did you mention me?
Oh, go ahead, Amit. You wanted to
Okay.
discuss your thoughts? Yeah, thanks.
Yeah, I was thinking based on the clinical symptoms, we were kind of pondering that it might be electrolyte imbalance because in methanol, as you have already mentioned, Dr. Ravi, that you mentioned that there might be there's a high chance of metabolic acidosis, and it could be a reason that there would definitely going to be some kind of electrolyte disturbance. So it might be a reason for all the memory problems, the diplopia, the vertigo. So we're thinking about that. And again, we're thinking about the metabolic compensation, because it's already had been 3 days, and the kidney might be playing a good role to compensate, and that might be a reason that the vitals are kind of stable. There's no increase in respiratory rate, or the heart rate and BP. So it might be a reason. So we were kind of pondering upon this too, and we also thought that um, uh, the I think it's very rare. I think it's a stupid thing to say, but I'm going to spit it out anyway. If the Parinaud syndrome, I was thinking about it because when you were when I was preparing for the STEPS exam, whenever you cannot gaze upward, so the first thing that comes in the brain was like Parinaud syndrome. So can't look up is equals to Parinaud syndrome was in my head. So we were kind of discussing that also in the group. So yeah, we just could discuss this much.
Oh, Amit, that's a really great thought, actually. And are you zooming in from the fabulous country of Nepal?
Yep.
Oh, whereabouts? Kathmandu?
Yep. I'm in
Oh.
Kathmandu, and it's 11 p.m.
Oh, wow. Thank you for joining. Is this the first time you're discussing or sharing your views?
No, I have presented a case in this team, and my case was non-Hodgkin lymphoma, which was masquerading as the Guillain-Barré syndrome. So I presented the case. It was in July, I guess.
Oh, wow. And good luck. Thank you for sharing your thoughts, and good luck in the match.
Thank you very much, guys. I really love your presentation and everything. Thank you.
Thank you.
Thank you,
I
Amit.
guess,
Ravi, excellent skills at localizing the discussant. No, I really like the idea of Parinaud syndrome. It's also helpful to use analogic reasoning to know where to localize in the CNS, because you were mentioning like Parinaud syndrome in the midbrain, so that can help us know like, oh, could the lesion be there? So no, I really like that idea. So back to you, Shiar.
I love everyone's thoughts so far. So let's give you all some labs. First, I have to say urine toxin screen was negative. Methanol in the blood was negative, and vitamin B12 levels were normal as well. The patient received thiamine and B12 anyways. His white blood cells were 4.5. His hemoglobin was 13.7. His platelets were 167,000. His sodium was 137, his potassium was 3.5, his urea was 31 with normal range being 18 to 55. His creatinine were at 0.9, his glucose was at 121, his HbA1c was 5.4, AST 21, ALT 36, alk phosphatase was 136, CPK 74, LDH 350, pH 7.4, bicarbonate 25.6, and PCU2 at 40.5. I'm gonna put all of this in the chat as well, and I'm gonna give you guys some time to discuss. Oh, sorry, I have to mention the CT head was normal too. No lesions on CT.
okay, great. We were contemplating the labs. The labs could give us enough momentum to get to possibly the diagnosis. Maybe something that could pivot us here is the bicarb is 13. Is that correct?
25.6.
Oh, 25.6. Okay. The urea is 13. Okay. So it doesn't pivot us. Well, it pivots us away from maybe the toxidrome and the anion gap acidosis and so on. But just sort of eyeballing the hematology, pretty much normal here. Chemistry, there is a slight hypoclemia, and urea a tad bit elevated. The liver enzymes, we're not even seeing, I don't see the AST, but if there is a 2-to-1 manifestation that could be secondary to alcohol use disorder. But not much to go by here, right? So does this kind of lead us to well, as far as the labs leads us to a diagnostic, I like this term, dead end, as far as the metabolic complications, right? So now we need to return back and go down the neurological disorders that we had thought about as a potential cause. So neurological, anatomical structures within the head. And even though CT is negative, CT is not going to allow us to look at the soft tissue of the brain, vessels. You need to at least give some intravenous contrast. So maybe the imaging will give us the answer. But at this point, Youssef, anything, are you able to squeeze out anything from the labs?
Similarly, like reassured that this is not related to like a sodium level, for example, or any like particular like severe metabolic derangement. We see an LDH that's a little bit elevated. This can be associated like sometimes with like hemolysis or other like rapid cell turnover like malignancies. And then the other big idea, like you mentioned, is could this also be like another toxidrome that's not detected? Like could it be a contaminant of moonshine, like lead poisoning contaminating moonshine, for example, or other contaminants that we haven't thought of that we can, like, I think I'll put them into Google shortly, or if anybody can help out and let us know like what contaminants could be inside like methanol or moonshine, that could be helpful as well, because that's what I would be doing in real life.
Yeah, here's something, Youssef, now I guess this is where you sort of have to wipe the slate clean and now formulate a problem representation within which we were probably putting front and center was this methanol. But now this common cold last week, we really didn't pay attention to this, but if you think about it, a common cold last week, what do you think could manifest like this from a common cold? And then the patient, I did like your comment this morning, like neutropenia can be a indicator of a virus, and that can be helpful. Like with a patient with asymptomatic, say COVID, neutropenia. I mean, neutropenia could be, or lymphopenia actually could be indicated that patient could have a virus, but I don't see a fever. But then the patient may not manifest with a fever. But what does that do for you?
Yeah, like I think we were discussing before, like how to differentiate between a possible like viral etiology or a bacterial etiology, and we don't see here any symptoms of like severe bacterial infection. So could they have been like exposed to a viral organism, or not organism, just a viral bug? Like definitely. Do we see any signs of like CNS, like viral infection? Since we're very good at detecting severe disease, but we're not good at detecting like mild uh, encephalitis. I think it's like definitely on the differential, but I'm not sure. Like I would jump to getting an LP before getting an MRI in this case to make sure this is not a structural case. And I think I would get like a lead level, and these are the things I would do next. What would you do next, Ravi?
I really like that. Yeah, at least to get an MRI and then think about maybe sampling the CSF. There's not a lot here that's screaming out maybe viral meningitis, encephalitis, but you don't necessarily always have to have a fever. With the physical exam maneuvers, if they're there, they can be very helpful. You have Brzezinski, Kernig's, Jolt tests, and so on, but they're not very good sensitivity, specificity wise. So even if they're not there, you could still have, many times I presented a case here of a viral encephalitis without any nuchal rigidity or any meningeal signs. So I like proceeding in that order that you mentioned. So getting an MRI, and then if nothing is, you can't decipher anything from that, then go for the CSF, and then also maybe consider autoimmune workup in this case. But should we move back to the next aliquot? Okay.
Okay, so thank you for the great discussion. We didn't think about the possibility of lead poisoning. I'm gonna keep that in mind for my next cases. Now I'm gonna show you guys some cuts from the MRI. Sorry for the quality of the images. And this is kind of the thing that revealed the diagnosis, but I'm gonna let you all discuss it first before sharing it. So everyone can see my screen. Yeah, I'm gonna let you guys discuss the images.
I don't read a lot of MRI brains often. I think as far as I can tell, is that there's a lesion possibly in the midbrain, but I can't take it a lot more than that. What about you, Ravi?
Yeah, I just looking from top to bottom, you're right. The bottom two on the left side of the ventricle midline, there is this hyper intense circle. So I think it's also seen on the upper right side. Oh, there's a little arrow there, but the arrow's not pointing to anything there, but maybe in the midline there as well. Uh, but I would say the bottom two and left side of the ventricle there in the midline, that may be the lesion that may be causing all this. Yeah, otherwise, I don't see any at his age. I don't see a lot of atrophy with chronic alcohol use disorder. You can get cerebral atrophy forming. Sulci aren't exaggerated, ventricles aren't dilated, but just that little abnormality. I agree with Youssef. Yeah, is that Kashira? Is that what you guys found?
So I'm gonna read the official findings first, but localizing what caused the lesions is a little bit difficult, especially with the cuts I got. We have to like see the whole picture. The official reading was that on DWI cuts, restricted areas in symmetrical pre-aqueductal and bilateral thalamic regions suggestive of recent ischemic infarctions with hemorrhagic transformation in territory of Percheron artery. So this revealed the final diagnosis as acute ischemic stroke, but I think we all want to know how all of these lesions map out to the symptoms that we saw. So if you guys want to discuss that before I go there.
Oh, so just repeat that again. There's hemorrhagic conversion?
Yes, there was hemorrhagic conversion.
And whereabouts? So a number of us was sort of talking about on the upper right side, near the left frontal lobe. There's a little abnormality. Is that just the cut, or is that also an abnormality there?
That may just be a mistake on my side. Like this
Okay.
is just, yeah, that was normal. On other cuts, it gets normal.
Yeah. So that could be. Remember, Youssef, just going back to our theory with the change of position. So we're thinking, what could change in position, or what could decrease pressure on structures so a mass can move? Vessel, less likely a stroke, wouldn't move. So there would be no change. But I guess if there's blood, or if there's a aneurysm, I just wonder, could that also change, or the pressure that it exerts on structures, could that also change with position? But with the hemorrhage, I'm very worried. Where would the hemorrhage come from? It could be a post ischemic stroke, hemorrhagic conversion. Could there be a vessel that's also bleeding? But any thoughts at this time?
And similar to you, this sounds like close to the midbrain, I think, causing like a vertical gaze, it looks like. And I was worried about like methanol, like induced like ischemia, necrosis. Could this be like transformation of like a stroke? And like Adam mentioned before, could this explain the positional sense of it? Like potentially, that's what I'm thinking of. And then for like etiology for and Khashiyar, you mentioned there's more than one lesion, is that right?
Yes. There is one big lesion we all are seeing in the thalamic region. There's another one that is a lot harder to see on these cuts. I'm going to discuss that next.
Okay. Do you want to then tell us about the lesion as well?
So I tried to get a good picture of it. The upper left one and the upper right one are trying to show those, but I don't think I'm successful in that. I should have gotten the DWI cuts as well for you guys to see it much better. But so the main question here, other than the etiology of the stroke itself, is how the symptoms are related to what we're seeing in the MRI, and are those explained by this? Because if they're not, we have to look elsewhere. We can't just sit still and call it a stroke. But the lesions fortunately do explain the symptoms. We see thalamic regions which can manifest as the loss of consciousness we were seeing, especially with the hemorrhagic transformation leading to the second episode. And there's another region that is affecting the pons. It's a lot harder to visualize and is actually missed on the official reading. I just asked my attendings and they showed me like this is what's causing the patient not being able to move their eyes vertically. So yeah, that's the case.
So interesting when you put it, the MRI finding in the chat, you mentioned the artery of Percheron. I've never heard of that before, so I just Googled it, and it's a rare anatomical variation in the brain vascularization in which a single arterial trunk arises from the PCA to supply both sides of the thalamus and midbrain, which you had alluded to, thalamic issue. And if there is a issue with that vessel, functions of thalamus and midbrain, including regulation of consciousness, sleep, and alertness, are affected. So another interesting thing, yeah, with multiple different areas, I just wonder if there's an embolic phenomenon. I think Elena had mentioned that in the chat, so that is an interesting phenomena. But yeah, basically with this toxidrome, this mentioning of possible toxidrome, this patient coming in, you definitely have to consider the CNS and other garden variety causes of such a presentation. What do you think, Youssef?
Yeah, I think similar to you, like when thinking of multiple strokes, I think of like the heart and AFib or embolic phenomena, the carotids, but then the other big category we often like forget is like the vessels themselves. Could they either vasoconstrict or have like a vasculitis? But I think methanol itself could cause like vasoconstriction, and that alone can explain the multiple strokes without like a necessary need for like a secondary etiology. But obviously you would do the workup anyway, but I think that's like would be like a possible explanation.
So interesting if we switch to management reasoning, as Youssef, whenever I see you, I think management reasoning. In this case, with the hemorrhagic conversion, we would have to, with an acute stroke, although we don't know if this is acute, we usually allow for permissive hypertension, right, for about 24 hours, unless the blood pressure reaches a target of 220 or above, at which time you have to implement antihypertensive therapy. But with this hemorrhagic conversion, you have to bring the blood pressure down, and that way you reduce the force of perfusion, maybe making the hemorrhage worse in this case, and then also do the workup, as people have alluded to, doing an echo, putting the patient on statin, high intensity statin. Aspirin you would hold until this resolves. In some patients, you would do dual antiplatelets for first 28 days, but in this case, because of the hemorrhage, you would have to hold that, and then also do risk factor reduction modification. Yep, and Lena, optimized diabetic therapy as well. Very good. All right. Thank you. Any reflections, Kashir, on this case? It's an amazing case like I've never seen. Methanol toxicity, and then especially coming with another thing in the background going on.
Yeah, the case was interesting in that we are initially on something very metabolic, and then we get all of the neurology and the metabolic stuff get out of the picture. The localization itself was very interesting to me, like how does the lesions correspond to the symptoms we were seeing? And the lesions here were really matching up one-to-one with the symptoms, which was really interesting to me. And I love the discussion.
Thank you, thank you. Thanks, Youssef. Great discussion and great doing this today with you again. So thank you for coming on. And I believe we have Julia doing the teaching points. Oh wait, Harry's doing the teaching points. Hey, thank you, Harry.
Thank you. Yeah, awesome case. I learned a lot. I hope everyone else did too. Just to go through the teaching points that we have, we started off thinking about methanol toxicities, and Youssef had said, told us that alcohol toxicities, whether it's methanol, ethylene glycol, usually manifests as a very high anion gap metabolic acidosis with a particularly large osm gap. And then we learned methanol is metabolized to formate and usually presents with visual changes, including blindness, can be treated with activated charcoal and fomepizole. And you can also test with the methanol level. We also talked about not anchoring on people's health-related behaviors. And when we have a patient with the loss of consciousness, just our broad workup, including checking the sugars, considering seizures and syncope, as well as our classic MIS mnemonic for altered mental status. And then a brief framework on diplopia. It can be either binocular or monocular. Binocular just is really an issue with eyes of not being aligned. So you can test it by having a patient close one eye. And if the diplopia resolves, then it's more likely binocular. And the differential for that includes muscle weakness due to a stroke, peripheral nerve issues, neuromuscular junction disease like myasthenia or muscle entrapment, whereas monocular is more likely to be due to eye disease like cornea disease, lens disease, macular degeneration, or cortical disease. We briefly talked about the hint exam, which is the head impulse, the test nystagmus, and test of skew, and that can help you differentiate between peripheral and central vertigo. A lot of discussion about vertical gaze palsy, which I learned a lot from. Ahmed taught us about Paranoid syndrome, and the differential of which is lesions of the midbrain, infarct, hemorrhage, infection, inflammatory etiologies, hydrocephalus, mass, and demyelinating disease. And then I personally learned about Percheron artery for the first time, which is a posterior circular variant that supplies the paramedian thalamus and the rostral midbrain, and in this case, mapped onto our patient's disease really well.
Thank you
Thank
so
you,
much,
Harry.
Harry. Yeah, that was a great summary. Thank you all for joining. I hope you all learned as much as we did. Can't wait to go read about all of this and toxicity. Thank you, Julia, for doing the scribing today. And if any one of you wants to present a case, you can just sign up on the website where they happy to take any case that doesn't have, it can be bread and butter or anything common. We're happy to discuss as well. So thank you all for joining and hope you all have a wonderful Tuesday.
Thank you. Bye.